Dr. Samuel Shor, developing his longstanding fascination of chronic fatigue in the late 1980s, he cultivated this interest in managing associated conditions such as fibromyalgia and ultimately Lyme disease. He's provided a congressional presentation of Lyme disease on Capitol Hill, September 24th of 2008, and has twice been interviewed on the nationally syndicated Diane Rehm Show, and most recently on July 3rd of 2019, the Kojo Namdi Show. Dr. Shor participated on the 2010 Virginia Governor's Task Force on Lyme Disease and is a past president of ILADS, the International Lyme and Associated Diseases Society. In 2011, Dr. Shor published original research providing evidence that the majority of his CFS patients in that study were actually presenting with blood test negative Lyme disease. He is also the lead author in the 2019 ILADS consensus definition of chronic Lyme disease. Dr. Shor has a strong interest in educating the public and medical communities while actively involved in the inpatient care. As such, he's been involved in the development of the Tick-Borne Illness Center of Excellence in Woodruff, Wisconsin. For more information, I think Dr. Shor will have a link for you to check it out, but the Wisconsin clinic can be found at howardyoungfoundation.org/Rick-Borne Illness. So with further ado, I'd like to introduce Dr. Shor. Thank you for joining us.
Thank you. I'm glad to be here, and thank you for the opportunity to participate. What I'm going to be talking about tonight is certain aspects of Lyme disease, but before I do that, just wanted to give some disclosures. I have no relevant financial or non-financial relationships to disclose, other than I am an employee of the Tick-Borne Illness Center of Excellence and past president of ILADS, as mentioned. Also mentioned here, and this is a slide that I will leave up at the end of the talk that has the URL of the Howard Young Medical Center, Tick-Borne Illness Center of Excellence in Woodruff, upstate Wisconsin, just 3.5 hours east of Minneapolis. And yes, we are seeing patients. So what I'm going to talk tonight about is particularly prevention, acute Lyme, and then review the chronic Lyme disease definition that we published in 2019. In relation to the management of Lyme disease, the most important component is prevention. Certainly, if we can prevent people from getting ill, then we've really done a service to them. In order to do that, there are a number of recommendations I'm going to review with you now, such as depicted here in the picture, trying to create a safe zone in your backyard, particularly if you have children playing in the grass and the area outside the perimeter of your house. Keep the grass cut short, avoid long grass, avoid leaf litter, discourage deer and small rodents, consider targeted tick treatment, and be cautious, do tick tests or tick checking, as we'll talk about in a moment as well. But if you do go into an area that you feel may be tick infested, you want to ideally walk in the center of established trails to ideally avoid contact with overgrown grass, brush, leaf litter, etc. However, if you do anticipate walking in those kinds of areas, there are some things that we do recommend I'm going to go over in a slide, but I did want to make a comment by Dr. Stafford et al. That most patients do become infected near and around the home. So if in fact you are going to be walking in high-risk areas, and unfortunately Wisconsin is an endemic region, meaning that there is a higher incidence of tick-borne illness in Wisconsin than in many other states, we recommend you wear long sleeve shirts, long pants to keep the ticks off your skin, and tuck the pant legs into the socks and tuck the shirt into the pants. So we try to minimize the likelihood of the tick crawling underneath the clothing. Wearing light colored clothing helps one see the dark speck of tick as opposed to wearing dark clothing where that would be more difficult to see. And using pre-treated clothes with permethrin can often help decrease the potential of contracting or getting a tick bite. With respect to acaricides or solutions that kill ticks, permethrin should not be applied to the skin, but DEET can be applied, as can picaridin. And this slide goes over some of the do's and don'ts that DEET does repel ticks, but picaridin may not. So DEET is probably a more reliable source for prevention of tick bites. An important point to emphasize here is protect your pet, particularly if they wander in tick areas. That also to be very cautious that when you have a tick, an animal wandering in tick infested areas, that you do a tick check on them as well, that you don't rely necessarily on their front line of application, which can be helpful, but ticks can jump on the animal and jump right off just before entering the house. And they can potentially then wait for you on the couch or bed or wherever and potentially expose you at that point in time. So you want to do tick checks on your animals and of course on your children and on yourself if you are in a environment that puts you at risk. And don't forget the hidden areas such as the groin, the underarm area behind the ears. Now, in terms of tick removal, you don't want to use a lighter, a fire lighter. You don't want to use oil. What you want to do is gently sliding the equivalent of these pincers under the tick, as you can see, to just kind of gently lift it. And you can just kind of poke it a little bit at a time, just gently lifting, because you don't want to leave any body parts in the skin, or for that matter, disrupt the integrity of the tick itself, where it can then empty its contents into that open wound. You want to try to remove the tick as a whole entity. Now, what do we do about treatment of tick exposure? Well, there are two different schools of thought. One school of thought suggests that one dose of 2-doxycycline is adequate. Unfortunately, many believe that recommendation comes from a flawed set of guidelines, such that the recommendations are felt not to be adequate.
Now, where's the volume?
Right next to it.
Here?
Hello, if you could turn off your volume.
Not doing anything.
Sure, it will.
Okay.
Just stay away.
We hear-
Click.
I've got it.
Click.
I've got
Okay,
it.
good. I'm glad you've got it. There we have it. That the prophylaxis
No.
that iLads is recommending is that if
don't
one
need that.
feels confident that
We want-
tick
We want the
is,
volume.
excuse me, there are people talking.
The
Thank you.
volume.
That the doxycycline
Where?
should be used in
options.
the event that we feel a tick has embedded. According to the CDC, the recommendation is 36 hours. There's evidence that deer tick can transmit Lyme disease in under 24 hours, and in one brief study under 18 hours. And depending upon the type of bite, if, for example, a tick starts to become engorged but drops off and then attaches either to another host or the same host, they've already started the process of having the gut contents move towards the pincers and then into the host. And it's because of that delay that we say it takes time. However, if a bite has started and then it resumes, the duration may not necessarily be as long that's required for that transmission to occur. If a tick looks engorged, treat it. If you're not sure how long it was there, we generally recommend that you treat it. And when we say treat it, the ILADS guidelines, which are based upon murine studies, mouse studies, are for 20 days, doxycycline equivalent, 100 milligrams twice daily. You want to educate both prevention of bites vis-a-vis the conversation we just had, as well as symptoms and signs of Lyme disease in the event that should occur. Because although one may prophylax against transmission of Lyme disease, it may not always work. And we want to be cognizant of what may happen if it doesn't work. And we're going to go over that right now. Acute Lyme disease presents as a viral-like illness, including symptoms of fatigue, joint pain, sore throat, lymph node swelling. This can occur anywhere from 3 to 30 days after the tick bite. So it usually is some delay. It usually lasts anywhere from 5 to 14 days and can often present with this bullseye rash, which is a classic characterization of a rash. However, I want to emphasize a few things here. One, that the constitutional symptoms I just described may only last 1 to 3 weeks, or will only last 1 to 3 weeks, even if you don't treat it. And that puts the individual at risk of developing chronic problems. And there's a fairly high likelihood that a chronic issue can evolve if they are not treated adequately. This condition, Lyme disease, is the #1 tick-borne or vector-borne illness in the United States and in Europe. And this specific tick-borne illness is transmitted by the black-legged deer tick known as Ixodes scapularis. On the West Coast, there's a similar tick by the name of Ixodes pacificus. But often these ticks, which you can see are exceedingly small, are very often
Dr. Shor, I think you are muted. Can you unmute yourself?
There we go.
There we go.
All right.
There we go. Okay,
Yep.
that just happened
Okay.
right now.
Okay, good. Then I'll just say again, here is the larva, the nymph, the adult male, and the adult female deer tick. You can see how small they are in relation to this individual's finger. Now, you are sharing, and for some reason, oh, there we go. Okay, so the organism that is transmitted by the tick that is responsible for Lyme disease is Borrelia Burgdorferi. And we say sensu lato, which is this complex that includes a number of other organisms, different strains of Borrelia, if you will. So just for completeness, I'm going to name a couple. Some people may have heard of them. Borrelia sensu stricto is the major form that's found in North America and is also found in Europe. There's a smaller number of Borrelia myonii in the United States, and also in Europe, particularly are Borrelia guarinii and Evzeli. Now, it's important to recognize that this is a seasonal condition. What do I mean by that? Well, as you can see by this bar graph, the June and July timeframe is the peak incidence, starting in late April through early September, even into October. But particularly in the summer months is the height of the season for Lyme disease. And that represents the time where the nymphs are aggressively feeding and transmitting the condition. Now, geographically, the locations that are particularly endemic are the Northeast and the upper Midwest, including Wisconsin. Interestingly, in 2013, the CDC increased their estimate of new cases from 30 to 300,000. But in 2018, they increased it again, another 50, up to 476,000 annual new cases a year. And many people think that that may be underreporting as well. That this is a map that reveals the endemic nature of this condition in Wisconsin. The dark blue is the highest case incidence, and as you can see where the arrow is pointed is where we are located in our Tick-Borne Illness Center of Excellence. Now, chronic Lyme disease, we define as a multi-system illness with a wide range of symptoms and or signs that are either continuously or intermittently present for a minimum of 6 months. This was a publication for which I was happy to be involved with, published in 2019 in the peer-reviewed literature, Antibiotics. The illness is felt to be a result of an active, ongoing infection by any of several of pathogenic members, again, of the Borrelia Burgdorferi sensu complex, which we talked about a few slides earlier. The infection has variable latency, period signs and symptoms may wax, wane, and migrate. And there are so many different variables in how one can present, which contributes to the challenges we have in making the diagnosis. Now, that diagnosis or definition that I just mentioned is in contradistinction to that of the IDSA. Now, what is the IDSA? That's the Infectious Disease Society of America, which is arguably the most influential organization of its kind in the United States and in the world for that matter. And they provide many good guidelines in relation to a number of different infections. Unfortunately, I and others feel that some of the recommendations that come from the IDSA in relation to this specific condition are flawed. So that, for example, this statement, which was made in the 2006 version of the IDSA guidelines, stated that to date, there is no convincing biologic evidence for the existence of symptomatic chronic Borrelia Burgdorferi infection among patients after receipt of recommended treatment regimens for Lyme disease. Those treatment regimens range from 1 week of Zithromax to 2 weeks of doxycycline only. Those are what's recommended, not for prophylaxis, but for treating acute Lyme disease. And then patients with unexplained chronic subjective symptoms following treatment with recommended antibiotic regimen for previous objective manifestations of Lyme disease is this concept of post-treatment Lyme disease syndrome, suggesting that there's not an infection. Then what we did in our paper, which we rigorously reviewed the literature in an attempt to generate a solidly defined evidence-based definition that we could then use for research, for clinical use, to improve the benefit that people get for treatment, coverage, etc. And what we did was require that an individual for inclusion be ill for at least 6 months and have direct laboratory evidence of the organism by at least one of these 4 ways of evaluating. So they had to have been positive for either culture, PCR, which looks at genetic material, antigen detection, which looks at specific proteins, and microscopy with a special type of staining. So looking at it in a particular way under the microscope. And this involved over 250 peer-reviewed papers through the international literature. And in so doing, we felt that we could define two forms of chronic Lyme disease: those who have been previously treated and those who were ill but never defined as such and thus were never treated. So again, we called the untreated group CLDU, chronic Lyme disease untreated, and the other group CLDPT, chronic Lyme disease previously treated. And of the individuals who had never been treated, we identified the 5 most common symptoms that were described in these 36 papers that met inclusion criteria. That was joint pain, which is arthralgia, fatigue, sensation abnormalities, and headache, all 4 of which were also noted in the previously treated group. However, in the untreated group, there was also in the top 5 joint swelling, but in the previously treated group, there was, instead of joint swelling, impaired memory. Not to say that either group didn't have that other category, it was just in the top 5 groups. So this gives you a sense of the types of presentations, which is just the tip of the iceberg. In this slide, we mentioned that there were 19 papers in which we were able to identify individuals that fulfilled our criteria for previously treated chronic Lyme disease. Now, the ILADS definition we chose specifically just to include the infectious agent Borrelia Burgdorferi sensillatu, because we wanted to feel that we provided ironclad evidence and as such felt confident that that definition could be used across the board in the medical community. And interestingly, it's been virtually 2 years since I published this paper as the lead author, and I have yet to receive a letter to the editor discounting this definition, which I think goes to show the work that we did has paid dividends. Now, that being said, we also realize that people with tick-borne illnesses, Lyme disease in particular, are at this stage more often than not co-infected with other organisms that we call co-infections, or another term is polymicrobial, or many organisms. And there are those such as Horowitz and Freeman who provided a definition of chronic Lyme disease that included that reality. They described chronic Lyme disease as a symptom complex of Borrelia organisms and multiple co-infections. And Stricker and Fessler similarly describe Borrelia and associated pathogens that cause persistent infection. So I agree that when we're treating individuals at the point of care, that there very often are more than one infections with which we have to deal. But as this slide describes, our rationale was to hopefully provide generally wider acceptance in fine-tuning the definition to include just Borrelia, to improve patient access to care, and to provide a more focused cohort or group, a more homogeneous group from the standpoint of research. Now, one of the concepts I wanted to review was what I believe to be a perfect storm in relation to many people who contract Lyme disease but don't realize it. And they don't realize it for a number of reasons. I'm going to go over each of these ticks: the clinical presentation, diagnostics, managed care, and the political overlay that impact everybody in relation to this condition. The tick vector, as I'd mentioned, is very small. And in this one study in 2019, Negrovich identified that out of over 170 children, only 18% remembered having been bitten by a tick. Then we've got the bullseye rash. Well, there are some who believe the vast majority of individuals with acute Lyme disease develop this rash. Well, unfortunately, that characterization has been described otherwise in the literature, so that in fact, as low as 20% in the Horowitz report in 2019, with other reports as identified here, such that we believe on average 50% of people develop this bullseye rash. That being the case, there's often atypical presentation, so that an individual may look like a sunburn or a shingles or just a little burn. And it may be located in places that people don't see very easily, in the groin or the axilla, the underarm area, or behind the ear. So it's really incumbent upon us to carefully look for ticks. And then even a few days after one is out in a tick environment, to do another screen to look for rashes as well. Now, another characterization of increased incidence of individuals who are exposed is the expanding deer population. The natural habitat for deer are to live in the periphery of woods. Well, what are cul-de-sacs? That is human habitat encroaching into the deer population. Along with that, tick populations have increased. And even beyond that, the number of ticks that are infected, both with either Borrelia or other infections, has increased as well. Then we deal with individuals who are complaining of common symptoms. Who doesn't have fatigue or headaches or some pain or some mood issue? Very often people are peripheralized because they look well and are seen as complainers or somaticizers. You ought to see a psychiatrist. How many psychiatrists have referred patients to me saying, there's something organic here, I'm not sure what it is, but this is not a psychiatric issue. So the commonality of symptoms, the fact that very often people don't have clear-cut abnormalities on exam, very often clinicians who don't know better defer to it being a psychiatric infection. And then there's managed care, which is driving physicians to see more patients in less time. And unfortunately, particularly in the chronic setting, Lyme disease can be a multi-system complex issue that involves many complaints that are real. And clinicians are motivated to treat more with less, more patients with less symptoms, so that their volume can allocate the numbers that are required by managed care. Unfortunately, folks with these conditions warrant and need longer periods of management. The tests, the lab tests that we have, the most common that is promoted by the CDC and the IDSA as being a very sensitive approach, and the hallmark diagnostic approach that's recommended, is called the two-tiered system. What that represents is a screening test called ELISA, and then a confirmatory test called a Western blot. In the setting of HIV that uses the same paradigm, the sensitivity of the first test is 99+%. So you catch almost everybody with HIV. But then again, you don't want to tell someone they have HIV if they truly don't. So the confirmatory test is 98 to 99% specific. That's the kind of statistic you want to hear. Unfortunately, in Lyme disease, the same testing paradigm is about 50%. So that 1 out of every other individual with bona fide disease may be told by their clinicians that they don't have Lyme disease. And in fact, there are some states that require clinicians who order Lyme tests that they communicate to their patients. If negative and you're still symptomatic, continue to follow up with your physician. This does not rule out Lyme disease if it is negative. And then, of course, is the political environment to which I alluded that unfortunately encourages flawed guidelines, even to the extent of denying chronic Lyme disease previously treated, recognizing when they say chronic Lyme disease doesn't exist, they're not even discussing those individuals who have never been diagnosed and thus never treated. However, in this slide, I describe a study that John Alcott at Hopkins ran called the SLICE study. And in this study, individuals had to present within 72 hours of identifying a bullseye rash, and they were then treated with 3 weeks of doxycycline. So these are individuals who are identified quickly, treated quickly with the course of action that was recommended at the time. And even in that setting, after 6 months, 39% of that group remained symptomatic or had some functional impairment. Now, am I saying all of them had active infection that wasn't adequately treated? No, but I am arguing that likely a substantive number of individuals in that category did probably have infection that simply wasn't adequately treated with that course of action. And John Alcott emphasizes in that study that he does not try to describe the cause of these people's presentations, but just that it exists. There's also a plethora of evidence in the literature supporting, and I'm not going to go over any of these, but just to show that there are multiple different types of evidence of persistent active infection in the setting of individuals who were previously treated. And there are a number of mechanisms for that. Borrelia organism is felt to suppress the immune response in many different ways, including decreasing the ability of antibodies to be generated. The organism can change its outer coat. It can actually change into other forms that I'm going to show you in a moment. I alluded to the fact that it can change its outer surface protein, keeping in mind that the body needs a certain degree of stimulus in order to generate antibodies to attack proteins. If those proteins are constantly changing, if the immune system is suppressed and decreasing the body's ability to generate antibodies, then that individual's ability to have the blood test show that it's positive is going to be impaired, and their ability to actually fight the infection is going to be impaired. It is well established that Borrelia hides in many different types of cells, in heart cells, in muscle cells, in vascular cells, etc. That biofilm, which is a matrix that a colony of bacteria can generate, can protect that colony that is often a mixture of different bacteria and viruses and parasites, that protects that group, that colony, from being attacked by the immune system by antibodies. That I'm going to go into this next slide, which talks about this concept of persister cells. And that's the latest craze that with which we're dealing, because as you can see on the left, the spirochetal form is what we normally think of in relation to the active form of Borrelia Burgdorferi. However, under certain environmental pressures, that spiral organism can shift to the right into that cell wall deficient form called a round body form that is not sensitive necessarily to the same agents to which the replicating form is sensitive. Not only that, but when that environmental pressure goes away, that round body form can then shift back into the replicating form and back and forth. It's a smart organism. So I hope that I've provided some sense of understanding of what this concept of chronic Lyme disease represents. A chronic active process that results in ongoing signs and symptoms of individuals who either were never diagnosed and have never treated, or in some people who were previously treated. I do want to emphasize that the majority of people who were identified early and treated early with adequate treatment do get cured. However, there is this substantive number of individuals who unfortunately did not adequately respond to treatment that we call chronic Lyme disease previously treated. So I hope that this has been a reminder and an overview of prevention and acute and chronic Lyme disease, to emphasize that we are available at the Howard Young Medical Center, Tick-Borne Illness Center of Excellence in northern Wisconsin, to assist in the characterization and the management of patients with acute Lyme, with chronic Lyme, and frankly, with chronic conditions that may be Lyme disease or perhaps not. We will see many different characterizations of these folks and hope that we can provide that service to you. Thank you for your time.